All right, let's talk about renal trauma. When you're in the heat of the moment in the trauma bay, you need a clear game plan. That's exactly what we're going to build here, a step-by-step guide to help you make the right calls under pressure. Let's get into it. Okay, picture this. You're in the trauma bay. A patient just rolled in from a nasty car crash. You see gross hematuria, the pressure's on. What do you do right now? That's the exact scenario we're tackling. We're going to build a mental flowchart so you know the next step without even thinking. First things first, and this is true for any trauma, before you even start thinking about the kidneys, you have to assess hemodynamic stability. Is the patient stable or unstable? Because believe me, that single question is going to drive every single decision you make from here on out. Okay, so you've run through the primary survey and you've got the patient stabilized for now. The next big question that should pop into your head is this: who actually needs a CT scan to check out their kidneys? So here's your cheat sheet, your if-then logic for when to pull the trigger on imaging. And this is evidence-based. We've got grade B evidence saying if you see gross hematuria in a stable patient, get the scan. Same goes for microscopic hematuria if the patient is hypotensive. Now, the third one is a bit different. It's grade C evidence, but if the mechanism of injury is high risk, like a direct blow to the flank, you should probably image them even if you don't see blood in the urine. All right, so you've decided to get the scan. But, and this is a big but, you can't just order a generic CT of the abdomen. It's not one size fits all. The type of scan you order is absolutely critical to getting the answers you need. And this is the gold standard right here. The protocol you need to ask for is an IV contrast CT with phasing. Why? Because you need to see two different things. That immediate arterial phase, that's what shows you if there's active bleeding. But then you need that delayed or excretatory phase. That's the only way you'll spot a urine leak. Getting both phases isn't just a suggestion, it's a fundamental clinical principle. Okay, the scan is done. The images are up on the screen. Now our job shifts. We're no longer deciding if we need to look, we're figuring out what we're looking at. What are those telltale signs, those high-risk findings that scream, this is a serious injury? Think of it like this. Certain findings on that CT are like bright, flashing red lights. They're the signals that tell you this isn't just a little bruise you can watch. This is something that could seriously threaten the kidney or even the patient's life. Let's start with a number I want you to burn into your brain. 4 centimeters. 4. If you see a perirenal hematoma, that's blood pooling around the kidney, and it's bigger than 4 centimeters, that is a huge deal. It's a finding that really starts pushing you towards doing something more invasive. So building on that 4-centimeter rule, here are the other big things we're looking for in those high-grade injuries. We're talking AAST grades 3 to 5. You've got that big hematoma, of course. Then you're looking for any sign of vascular contrast extravasation, a fancy term for active arterial bleeding. You're also looking for deep cuts into the kidney itself, and finally, any signs of urinary extravasation, meaning a urine leak. So you've gathered all this info, right? You know the patient's stability, you've seen the CT findings, and it all leads you right here to this major decision point. This is the big fork in the road for managing renal trauma, and the signpost is that one simple question: are they stable or unstable? And the two paths could not be more different. For your stable patient, we have solid grade B evidence that says non-invasive management is the way to go. We're talking observation, bed rest, supportive care. But if your patient is unstable, that same level of evidence, grade B, points you in the complete opposite direction: immediate intervention. That means getting them to the OR or to interventional radiology stat to stop the bleeding. So let's be really clear about the goal for our stable patients. It's all about kidney preservation. The whole reason we lean towards non-invasive management is to give that kidney every possible chance to heal on its own. We want to avoid an operation if it's not absolutely necessary. Now, you might be thinking, wait, a urine leak? Doesn't that automatically mean a trip to the OR? Well, not always. There's a really important exception here, a bit of nuance you need to know. And this is what we call selective observation. It's another one of those key clinical principles. Here's the deal. If your patient is stable, and the CT shows a urine leak that's contained, meaning it's trapped within the fascia around the kidney, and you're pretty sure it's not a major tear in the collecting system, you can actually manage these patients just by watching them closely. All right, so we've journeyed from the trauma bay, through the CT scanner, and right through the biggest management decisions. Let's wrap up by talking about what comes next, the follow-up phase. Who needs another look? So who gets another scan? It's not everybody. The grade C evidence tells us to reserve follow-up imaging for a few key situations. Definitely for the high-grade injuries, those AAST grades 4 and 5. And for any patient who starts showing signs of complications, they spike a fever, their pain gets worse. But for those straightforward, low-grade injuries that are getting better, you probably don't need to scan them again.
And to close this out, let's look to the future with a big question. We're seeing incredible things from interventional radiology, with techniques like angioembolation getting better and better. So are we heading towards a time when surgery for even the worst renal traumas becomes a thing of the past?